Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This week, we are again talking to Dr. Gara. Dr. Edit Gara is a MD PhD. She's on our teaching faculty for the DHS. Dr. Gara, welcome to the program.
Hi, Aebhric. It's fascinating to be back and to continue our pediatric topics in our podcast series. So today we will talk about the hypovolemic child.
So this is something that we see a lot in resource-limited environments. So I've been very much looking forward to this chat. So tell us about the hypovolemic pediatric patient.
Yes, so today I would like to focus on the hypovolemic child, and the reason is rather an infection-caused hypovolemia. So today we are not touching on the trauma and on the bleeding pediatric cases, so on on the internal medicine caused hypovolemia, because the trauma and the bleeding disorders, that's just a huge another topic. So today the topic is the infectious hypovolemic child. So in austere conditions, you can see tons of children affected by tropical diseases, such as malaria, such as cholera, such as helminths, which can cause severe infections. So those are transmitted with soil infection. And these children can be critically ill, and it's really challenges to treat them on the field and even to recognize that they are in a critically condition in terms of the volume status. So you can imagine these patients, they can have severe fever, they can have diarrhea, vomiting, even in really complicated cases. The whole infection can cause a gut obstruction, and these all can just worsen the volemic status of the child, and the severe pre-terminal hypovolemic status can come up.
So the assessment, so the hypovolemic child presents in lethargy, and so let's talk about assessment. So you have this child in a resource-poor environment. How are you going to know it's hypovolemic, and how do you assess that?
Yes, the assessment and the physical assessment is key. So today I would like to focus on that a lot, because it's extremely important to recognize that the child is in a critical condition in terms of the volume status. And the best way to do this in the pediatric population is the physical assessment. Later, we will talk a bit about other equipments which can be helpful to assess the volume status, and to mention the ultrasound. But here, first, I would like to outline that the physical examination is crucial, and it's much more important than doing any kind of ultrasound examination on the pediatric patient. So you do your ABCDE assessment, and you do it really critically and in details. And I just would like to give some hints and tips what to look for, what are the red flags in the hypovolemic child. So when you do the airway and breathing, usually so the pediatric patients, they are compensating really well for a really long period of time. And when you are assessing a hypovolemic child, you will find the compensating numbers in terms of the rate of the breathing, and when you move to see the rate of the heartbeat as well. So when you find normal rates in a child who appears really sick, then you should be really worried, because that means that the compensating phase is over and the child just turning into a terminal state. So usually there is a respiratory compensation for the hypovolemia, meaning that the child will be tachypnoic. if there's a critically ill child and you don't find the breathing stable or already hypooxygenated, then it's important to think about ventilatory support earlier than later, because just getting the child relieved of the ventilatory work can increase the volume and status, can have an impact on the volume and status as well. So, and then that just in the field, I wouldn't really recommend to if there's a way to do a quick blood gas test, or I wouldn't really recommend to wait for that, or to decide in the first assessment whether to intubate and ventilate. It should be a clinical decision.
So you're relying on clinical signs. You're not relying on like lactate levels or.
So or of course, on the longer term of your treatment, or if the child first was stable and you were not even thinking about ventilatory support, but later deteriorating, and you have the blood gas and you can analyze, then yes, of course, get as much information as possible. But if you are alone in a field and not much resource, not much techniques given, then it has to be a clinical decision. And the work of the breathing can be enormous for a small child. Just quickly, I'd like to go through the normal rates.
Sure.
The respiratory rates. So below the age of 1, it's around 30, 40. Between the age of 1 and 2, it's around 25, 35 per minute, the breathing rate. In the age of from 2 to 5, it's 25 to 30, and age between 5 to 12, 20, 25, and above the age of 12, it's around 15, 20, and above, it's like in the adult population. So just really quickly. Okay, and when you have to turn or you decide that you have to intubate, be careful with the anesthesia, because we know that most of the inductive drugs can even trigger hypotonia, hypotension, and it can just worsen the whole status. So the recommended first-line medication is ketamine, which in a hypovolemic patient, because it doesn't have that strong hypotensive effect.
So you would use ketamine. Would you use any muscle blockers as well?
Yeah. So you can use the quick-acting, the rocuronium, for example. So yes, if you have experience in rapid sequence induction and intubation, then yes, it's safer to use with the muscle relaxant. Okay, once you are satisfied with A and B, then you assess the circulation. Of course, you look for the color, you look for the capillary refill time, you look for the heart rate. I would like to mention again that the child is compensating, so they must be tachycardic. If the heart rate is normal, that's a severe red flag. You should take look for the central and peripheral circulation, and I mean to examine the extremities. Are they cold? Are they warm? Try to assess whether there is a toe to core gap, because it's important to have an image in your mind whether it was a constrictive status on the periphery, or rather it's a vasodilatory state.
Would you feel the temperature of the extremities? Would this be the time where the distal areas would start getting cold?
So yes, if you have equipment, yes, you can measure, or it's simply by palpation. And you can also assess the central and peripheral pools, the pulse rate as well. So these are the physical signs you look for. And the blood pressure, it can be tricky because it's maintained until very late phase of the whole illness. And when the blood pressure is already clearly low, then that's a pre-terminal state for a child.
Mm.
So keep in mind that they are compensating really well and for a really long time. Meanwhile, they are critically ill. And in the C, I would also like to mention the IV lines, how to perform if the child is younger than 6 years and critically ill and there's an immediate need for fluid resuscitation, then the recommended way is the intraosseous route. If you have experience in inserting peripheral IV lines and really strong hands-on experience, of course you can go for that. Otherwise, do the intraosseous, and it's recommended not to try more than 3 times the peripheral IV line. The femoral vein is a safe route. Again, some hands-on experience is needed to be.
And an ultrasound.
And yes, an ultrasound can be really helpful. That's really easily accessible by an ultrasound.
You know, the pediatric sticks are difficult in the best of days. Working in hospital, we would call in a pediatric nurse to do the IVs. And how difficult is this going to be with a hypovolemic pediatric patient and resource limited? And you're not going to have cook needles or IO. What would be your minimum better best option for getting fluid into the casualty?
You have to solve it. I mean, if you are in an ulcer condition and just you there, if you don't have an IO, somehow you have to have a peripheral line, or you can try the femoral, or also you can try the jugular vein on the neck.
Wow.
That's also easily accessible. That's more painful than the femoral. So if there's a peri-arrest state, then sure, go for that. Try that as well. I've done that a couple of times in peri-arrest or in arrest children. So yeah, that's quite kind of. I would say that's an easy line, the jugular vein on the neck.
Easy line. Wow.
Yeah, I would say that. Yeah, it's quite big, and it's if you turn the neck, tilt a bit and a bit backwards, then it's just it's a good anatomical position to reach it.
So doing the EJ, I've done it on adults. It's a negative pressure. It's so low pressure that you have to do the stick with a 10 mil syringe pulling back. Is that the same with pediatric? Are you using a 5 mil syringe or 10 mil syringe on your IV needle to be able to pull back on that to get a flash?
Yeah, like 2 mils or 5 mils syringes is enough in pediatrics. And otherwise, yeah, the same technique as in adults.
Wow, that would be frightening to have to do that on an infant.
No, it's not. It's not. So yeah, you guys listening, I'm sure you will all solve this. Yeah.
And what about dermoclysis for hydration?
Say that again. Sorry.
For dermoclysis, so subcutaneous infusion of normal saline. That it's in the World Health Organization protocols, but it is definitely a contentious option.
Yeah, so I think those who are listening to our podcasts are they have more equipment even in ulcer conditions, and
indeed,
and more trained to perform any kind of proper line. So yeah, for if you have equipment and some kind of experience, you can solve it. So I would not really recommend subcutaneous fluid administration, because it's just extremely hard to assess how much is just getting into the circulation. It's extremely the site would definitely suffer some tissue injury. It's a new place for more infection to come. So if there's any way to do any kind of line to administer fluids, then just the last remaining option, really last, to to give subcutaneous fluids.
And in nasogastric or oral gastric, what age can you start doing that as a hydration option?
You can start early on. Again, if there's a need for fluid resuscitation, so if there's a critically ill, not stable child, then oral nasogastric or oral gastric fluid resuscitation is just not first line. So it's not no way to clearly assess how much is absorbed. The gastric part, when the child is in shock, hypovolemic shock, there's really low amount of circulation getting into the whole gastric system. So mostly really tiny bit of the fluid would get absorbed from that part. So yeah, it's again a last remaining option. Okay, how to do the fluid resuscitation and what to give, and once you've done the line, and I'm sure the listeners will be trained enough to get a proper line, then the fluid resuscitation should be performed with a normal saline. So it's a normal sodium chloride, 0.9%. That's the recommended fluid in the guidelines. Any other kind of fluids are controversial in fluid resuscitation. So later on, when the child is already in the hospital, or you have more equipment to assess, and you can assess the blood gas, the sugar level, etc., even the ICP, for example, then you can give more sophisticated fluids or dextrose or gelatin. So then later on you can combine, but the first line, and in ulcer conditions, it's only in the guidelines, the normal saline is only recommended for fluid resuscitation. The dosing, it should be 20 milliliters per kilogram in a bolus. That's the first part you would like to give, and after the fluid is in, you always reassess the child, and you look for the signs of responsiveness to the fluid.
Are you looking at urine output as well?
Yes. So the guideline is saying that the urinary output, the normal, is 1 milliliters per kilogram per hour, which is it's just hard to estimate until there's no urinary cath in place. If the child is still wearing a nappy, you can look for signs of a wet nappy. There should be at least one in an hour or in 2 hours. That's a good way to assess.
So a rule of thumb is 1 nappy per hour for
Yes.
the medics out there. Okay.
Yes. Yeah.
That's a really good learning point.
Yes. And then if the child is not responding, then you give more fluids. The guideline says that if there's a need of 40 milliliters per kilogram or more, then you have to think about giving inotropes.
What would you give? What are the top 2 or 3?
So first line in a hypovolemic child would be the dopamine, which is recommended. The dose is 5 to 20 micrograms per kilograms per minute. So you give it in a perfusion pump, and the reason is because mostly there is a peripheral vasoconstriction, centralized circulation in a hypovolemic child, and you don't want to make the periphery even worse with administering noradrenaline. So that's the reason why the dopamine is the first line choice in a pediatric hypovolemic shock. When you have to give much amount of fluids, of course, there will be a hemodilution. Also, you really have to be careful not to overload the child. You have to look for some signs of pulmonary edema as well. And in many cases, later on, blood is often needed even when there is no bleeding at all.
Oh, really?
Yeah,
What
because
would be your indication for that?
just because there's, when you administer a lot of fluids, there can be a hemodilution, and simply just the red blood cells just can't work that effectively. And also most children under the age of 12, they are rather close to the part of anemia than being over loaded with red blood cells. So it's just like a pediatric key feature that so the amount of red blood cells is not that high, and they are just changing them really quickly. And if there's also, it's a response in a septic and in an infection condition, that these acute phase proteins are really quickly used, which can help even the red blood cells to circulate and bring oxygen to the peripheral parts. So it was mentioned in the guideline that blood sometimes, many times, even needed when there's no bleeding.
So would you give fresh whole blood or packed red blood cells, or what would the indication be?
Yeah, so first line would be just red blood cells, packed red blood cells. The condition, which is called the disseminated intravascular coagulopathy, the DIC, which is a really life-threatening and really severe one. It happens more frequently in pediatric shocks than in adults. Somehow just the immune system, the whole hemostasis is just more prone to this really severe condition. And in that case, you wouldn't really want to give more sophisticated blood products, just the packed red blood cells. And also, if you have any signs of strange hemostasis or signs of severe peripheral thrombi, microthrombus, for example, just getting the fingertips black or bluish, and that could be a sign of some peripheral thrombi. You have to consult it's rather a hematologist or a pediatric or neonatal intensivist, someone who has already seen or treated a DIC, because that's just extremely life-threatening. So careful with the blood products.
So you've assessed a hypovolemic casualty. You have treated with fluids, and if DIC happens, you're giving blood products. What else would you be looking to do with this casualty?
So I wanted to touch on the oxygen. Of course, any critically child is really responsive to oxygen, because the pediatric populations, they are much more sensitive to hypoxemia than the adults. And so just routinely feel free to administer oxygen. Just I would like to mention two cases when you be careful. One is when there's a known or congenital cardiac condition, because in those cases, hyperoxemia can be extremely harmful. And the other one is if there's any signs of meningitis and in severe infection, signs of meningitis, because then hyperoxemia can harmfully affect the intracranial pressure. All other conditions, giving oxygen is extremely safe and needed for the pediatric population.
Indeed. So what about POCUS? What about the ultrasound?
Yes.
How would you use this for this casualty?
So as I mentioned in the beginning, if you have an ultrasound, a portable one which is connectable with your phone, whatever, it's a very good equipment and it can give a lot of extra information. But I would like to avoid deciding the first line treatment on your focus examination. I mean, just do a really thorough ABCD assessment if needed, then ventilate, intubate, ventilate, give the fluids, reassess, and until the point that the child is in a pre-terminal or terminal phase. Just don't waste time with the ultrasound examination and with trying to interpret the results, trying to measure the IVC and how much it's collapsing, and then from that trying to decide the amounts of the fluids needed, and because meanwhile the child can die. So just in pediatrics, the ultrasound can be really tricky if you don't have much hands-on experience. Then it will take more time than you ever imagined. So be careful. But it's an extremely useful tool. And so when you have a portable ultrasound, what can you look for? You can look for the lung. You can investigate the IVC, the inferior caval vein. You can do a focused cardiac examination. You can assess the hepatic or the portal vein, and you can also do a renal venous ultrasound. And from all these, you can get some information about the fluid state. In the pediatrics, even finding the hepatic vein can be really tricky if you don't have much experience in pediatric abdominal ultrasound. So there are three on which I would like you to focus, and these are the lungs, the IVC, and the aorta in terms of the heart. So these three. Let's discuss them in a bit more details.
Okay.
So the lungs, assessing the lungs in the pediatrics with the ultrasound. So that's the best you can do with your ultrasound in your pediatric case, because technically it's easy. Interpreting, it's easy. Of course, you have to have a pediatric probe. Otherwise, the adult probe just won't fit in between the ribs, and you will only see the rib itself, which means you won't see anything on your ultrasound.
Right, so, or you need a phased array, don't you? Something that'll look in between.
Yes. So so check your equipment, whether you have one for the probe for the pediatrics.
So you're looking at the lungs for wetness, right? You're seeing if you have B lines, which will indicate you've overhydrated.
Yes, that's true. That's right. And imagine that if a chest X-ray would only be performed to assess fluids in the lungs, then it's not recommended, not in the pediatric ICU. It's rather recommended to perform an ultrasound of the lungs, because to avoid the radiation on the child. Indeed. By an X-ray. So it's such a good examination. And so once you've given fluids, started the fluid resus, and you are giving the third round, and you have time to assess the lungs, and you get the B lines, then just be aware that you are overloading the child. And if still in a critical condition, then it's extremely high time to start the inotropes. For example, this can be a good way to use and interpret your results with the lung ultrasound. Okay, so examining the lungs in kids is very good. What about the IVC? It's also good. It's in terms of the sensitivity for fluid assessment, fluid state assessment, it's around 80%. And when you measure the aortic flow variability, it gives, according to the literature, 92% sensitivity. So the IVC is it's not as strong in terms of the sensitivity in the pediatrics. It can be like when you haven't seen much pediatric abdominal ultrasound, and you are you get used to adults and you see a tiny IVC which is collapsing with breathing. It's really it's really easy to overestimate the amount of hypovolemia because they are just tiny. It's collapsing, and from interpreting the IVC, it's easy to overload the child with fluids.
So it's just because the tank of water is just not big, and so you have a tendency to overhydrate.
Yes, and also it's extremely hard to have the numbers in your head, like what is the size of a 4-year-old IVC, like if you are not doing it every day and just by trying to eyeball and get the impression whether it's normal size or whether it's enlarged, it's extremely hard to say in the field.
So with very small pediatrics, is it a good rule of thumb to look at the IVC and not measure it, but just look at the comparison of breathing in and not breathing? Would that collapse be enough to see the? Okay, good.
Thanks for saying this, because that's the key. Not just try to get the size, but if the collapse is around 50% with breathing, that's normal fluid status. If the collapse is less than 50%, then that's a fluid overload.
Okay. If more than 50% collapse, they need more fluid.
Yes, that's right. And if you can find the aorta, the abdominal aorta, and you can get a flow chart from that, there shouldn't be huge variability with the BPMs. So it should be mostly a constant, nice flow chart. If there's a large variability, then that's a sign of hypovolemia in the pediatrics.
So you can even see that in the abdominal aorta.
Yeah, and it's easier to find with the ultrasound in the pediatrics. Not much adipose tissue. Mostly they are thin patients, so it's easy to find the aorta in the abdomen. Yes. So to sum up the focus, use your equipment, use it cleverly, and try to interpret it really carefully. Try to focus on the lungs in the pediatrics, and if you can find the aorta, that's a good way to assess the volume status. Be careful with the IVC.
So this is a very good overview. So being a knuckle dragger, I like take-home messages. So the take-home message, the main points to look at is you're going to assess clinically.
Yes.
You're going to do aggressive rehydration. You're going to hydrate until there's 1 nappy change per hour.
Yes.
You stabilize the airway. You give inotropes, and you suggested dopamine as first-line inotrope.
Yes.
And then focus only at the end of the assessment. And what we're looking for is B-lines in the lungs for overhydration. And we're looking at an IVC. If there's more than 50% collapse of the IVC, they need more fluid.
Yeah, that's right. So focus is also really good equipment. I don't want to make you use it too early and waste too much time, and you are wasting time, and it might happen that you are interpreting it a bit clinically not so clearly, and meanwhile the child is just getting into a even worse situation. So first use your physical examination, and once you've started the stabilization, the reassess, then you have time to deal with the ultrasound.
So that's good advice. And for adults, it's probably good advice as well. We're not going to pull out the ultrasound unless we're looking for EFAS type a problem. Other than that, we're going to wait till we get through circulation to use the ultrasound. So,
I have much experience with ultrasound, but I never want to waste time. It's even in adults, if they are a bit obese or just they are a bit corpulent, it's extremely hard in a field situation to even get a proper view of the IVC, it can be really tricky to interpret. So until the patient is at least not mildly stabilized, I would say, I won't waste time with the ultrasound.
That's good advice. Any other points for a hypovolemic pediatric patient in austere environments?
Again, just to emphasize that they are overcompensating for an extremely long time, and then they are deteriorating in seconds. So just look for the physical signs of compensation, tachypnea, tachycardia. The blood pressure can be normal for quite a long time. So once you've seen a critically ill child with normal ranges of physical signs, then just an extremely red flag.
That's excellent synopsis, Dr. Gara. Thanks for bringing this to our knowledge.
Thanks, Aebhric. It's fantastic to be on this podcast session. I hope the audience is enjoying it as much as we do.
And we'll see you again next month.
Yes, see you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.